This conference will now be recorded.
Welcome in, everybody. On this lecture, we're going to be talking about emergencies for patients with special challenges, which is chapter 40 in your guys' textbooks. So first, we're going to be looking at disability, what the definition is, and some common patients that we could potentially see with disabilities. So definition, we're looking at a physical, emotional, behavioral, or cognitive condition that interferes with a person's ability to carry out everyday tasks, such as working and or caring for oneself. So kind of like our heart disease definition, this is a blanket term of a bunch of different things that can interfere with somebody's ability to actually care for themselves and or be a member of society at this point. With developmental disability, so this could be persisting or lasting, and this is going to be a mental and or physical impairment beginning at any age up to 22 years and causing significant impairment in the person's major life activities. So with these disabilities, we got to be conscientious of them and how they affect our patients, and then also how they affect how we properly care for them in the different treatments and interventions that we're going to perform. With that, oftentimes these go into how we're going to properly and safely move that patient from whatever their position is into the stretcher and then eventually into the ambulance. Next, we're going to be talking about terminal illness. So a terminal illness could be referred to as end-stage cancer, different types of heart failure, kidney failure, or progressive fatal diseases as well. So with that, oftentimes these patients are going to have paperwork and different components in correlation to our EMS legal aspects, such as our DNRs, our DNIs, which stands for do not intubate, and any other type of advanced directives. Oftentimes, as far as what we're going to be doing as EMS care, any type of interventions, this is going to be correlated to comfort care, depending specifically on what they wish within their DNRs, DNIs, and advanced directives. A lot of these individuals at the end stage of their cancer, their heart failure, whatever their terminal illness may be, is going to be located in hospice care. So the only hospice care facility that's actually located in our area is referred to as Solvay Hospice House, and this is located pretty close to the Copper Top Church. Now, as far as EMS providers, we don't get called to these hospice care houses all that often because basically they have skilled nursing individuals there that are ready to take care of that patient, and they're kind of just progressing them into that end of stage life. Next, very common call that we go on is individuals who are obese, whether this is some other type of ailment or an ailment that is specifically related to their obesity, but it can create quite a few different special challenges for us when we are dealing with patients who are classified as that obese mark. So bariatrics, this is a branch of medicine that deals with the causes of obesity and as well as prevention and treatment for these individuals. Definition of obesity, this is a condition, too much body fat, and it's defined as that BMI of 30 or greater. Now, modern medicine, we're starting to get away from that BMI component because individuals who have a large amount of muscle mass or just different genetic makeups oftentimes hinders what that definition or what the specific use of that BMI component actually is. So this is how we actually calculate that BMI. So we take the amount that that individual weighs, and then you're going to divide it by the height in inches times 65 times 65, and then we're going to multiply that by 703, which is the specific BMI component for the individual who is that height. And as a result, that BMI component would be 22.46. So looking at that, that's relatively high on the BMI chart. And when we think of individuals who are 135 pounds at 5'5", we would probably consider them to be relatively small. So the big challenges when we are dealing with individuals who are obese is trying to figure out a proper plan in getting them from whatever position they are currently in to the stretcher and then into the ambulance. With that, ambulances only have certain capabilities as far as actually getting these patients from their home or that care facility to the emergency room and to the hospital. So for here, this is a picture of a specifically designed bariatric ambulance. So it's actually got a lift gate on it. And then with that lift gate, there's a specially designed stretcher that is going to exceed our normal value for stretchers. Oftentimes the stretcher is going to be right around 400 to 500 pounds as far as weight capabilities. And then with bariatric stretchers, oftentimes we're going to be able to get to that 600 to 700 pound weight limit for these individuals. So here is an example of that bariatric stretcher. Now there's a couple of different ways that you can actually tailor a bariatric stretcher. This is specifically both the undercarriage and then also the lane format is all designed for the bariatric. Now other stretchers, what you can do is you have a undercarriage, which is your normal undercarriage stretcher, and then you have different components that you can actually add on additional room for your bariatric patient. So that's what Gold Cross oftentimes utilizes with their manual stretchers. Now with their powered stretchers, they don't actually have any type of additional room that they can provide. And that's where they're going to actually just lay down those armrests in order to create that extra room for these individuals. So when you are responding to nursing care facilities, oftentimes they will have a gurney lift, which makes our job much safer. It's much more comfortable for the patient. We are not trained as far as how to properly operate these, so we should use direction and guidance from the care facility staff. They will actually be operating this. What we want to do is just get our stretcher as close as we can underneath, and then they can use that gurney lift to go ahead and lift that patient up from that current position and then on your stretcher. So remember this too when we were talking about EMS wellness and injury prevention way back, is one of the things that makes us end our career very, very quickly is back injuries. So again, when we're dealing with these bariatrics, if we do have the capabilities of using that gurney lift or getting more hands on that patient, the better as far as lifting and moving techniques. Another common occurrence that we come across is the homelessness and poverty. Now this creates quite a few different issues as far as special challenges go. Oftentimes the biggest issue is actually finding the patient. Because they live underneath bridges or different highway segments. When they do call 911, or if somebody calls 911, then it can be difficult because there's not a specific address, which is correlated to some of these homeless parks that we may see in the Duluth, Superior, and surrounding areas. Oftentimes they do have a number of different serious medical conditions. And then on top of that is a lot of times they are not actually being treated for those serious medical conditions. Could also be dealing with emotional issues. Oftentimes these individuals are or have gone through significant changes in their lifestyle, and basically a string of bad luck. And that's why a lot of these individuals no longer are residing within a home or an apartment and actually have to abide by these different homeless capabilities. Next, autism becoming more and more common as far as dealing with our pediatric population and other individuals. So this is actually a pretty good video showing that autism.
This conference will now be recorded.
A lot of people talk about autism, but not everyone understands what it is. Autism spectrum disorder, or ASD, affects how people communicate with and relate to others. This isn't the same as being shy or not knowing what to say. Most people with autism don't understand some of the basic social conventions that others take for granted. They might have trouble making eye contact, holding a conversation, or recognizing gestures. And over 1/3 of people with ASD are nonverbal, meaning they don't use speech. Along with communication issues, people with autism often like to follow certain patterns or repeated behaviors. Many have a sensitivity to bright light or loud noises, and others have physical problems like trouble walking or picking up small objects. Some have intellectual disabilities, but about half have average or above average IQs. It's also common for people with autism to have a great long-term memory for certain details, and many excel in math, science, music, or art. With such a wide variety of symptoms, no two people with ASD are alike. The behaviors vary so much that they used to be classified as different disorders. One was Asperger's syndrome, where people obsess over particular topics, miss nonverbal social cues, and may not understand appropriate social behavior. In 2013, scientists realized that the boundary between Asperger's syndrome and some of the other disorders was fuzzy, so they decided to put them all under one name. This made it easier to diagnose autism, which is important. The younger someone is diagnosed, the earlier they can get help. In fact, many children who have autism will show signs by just 2 years old, including not responding to their name, avoiding eye contact, and flapping their hands or rocking repeatedly. Even though there is no cure for ASD, therapy and medication can help people adjust. Scientists are also doing clinical trials to find other solutions. They've learned that 1 out of every 68 children in the US has the disorder, but they still aren't sure what causes it. Autism is over 4 times more common in boys than girls, and most scientists think genes play a role because it often runs in families. Some people with ASD have abnormal chromosomes, but this can't be the whole story. There are people with the same gene changes who don't have autism. Other possible causes include having older parents, being exposed to high levels of testosterone in the womb, and having complications during pregnancy or birth. It may even have something to do with gut bacteria, since many autistic people have gastrointestinal issues. But most likely, it's a combination of many factors. The one thing scientists know for sure is that vaccines do not cause autism. No matter why it happens, ASD is being diagnosed at a higher rate every year. This doesn't mean it's becoming more common. It just means more people are aware of the condition and getting diagnosed early. And awareness is crucial. The more we learn about autism, the more we can understand and relate to those who have it. It's important to note that people with ASD deserve the same respect, fairness, and chances that people without ASD receive. This will help people with ASD adapt and grow in our communities. We've put some resources in the description if you would like to learn more about ASD and figure out what you can do to help. Is there another disorder or any other topic you would like us to talk about? Let us know in the comments section below. And if you would like to learn more about OCD, we made a video on just that. Check it out. Or if they obsess with safety, they might force themselves to check that the doors are locked and that the stove is off dozens of times before they can leave the house. My name is Blocko. This has been Life Noggin. Don't forget to keep on thinking. Hey there.
So it's just a brief introduction to autism and what they may be dealing with. Again, this is pretty common occurrence among populations nowadays. We saw the statistic that it's 4 times more likely that boys will develop this in comparison to females. As far as challenges within patient assessment stuff goes, oftentimes individuals who are diagnosed and live with autism, they're able to deal with it and then still become productive members of society. Once they hit a certain age, they're able to kind of wrinkle out some of those different capabilities. Where we really run into issues is that younger pediatric area of their lifespan development and trying to deal with their autism, and then also getting a good medical history and actually properly treating those patients. So some tips, use the basic module. Under the basic module, what we're going to be doing is keep all of your instructions very basic, and then also treat them with kid gloves. So whatever you do as far as interventions go, let's say you're going to check a blood pressure or listen to their lung sounds, let them play with that blood pressure cuff or play with that stethoscope prior to actually putting that on their body. It makes them feel quite a bit more comfortable. Make sure that whoever and whatever caregiver is there that they feel most comfortable with, make sure that they are actually right by the side of the patient who deals with autism. It makes them much more comfortable. Try and limit any type of interaction on the outside environment the best you can. So try and keep it quiet, because they do have the tendency to get relatively distracted, or they'll kind of go into their shell if there's any type of loud banging or any type of overstimulation. So we touched a little bit on this within chapter 39, which was our geriatric, but different healthcare settings. First, we have nursing homes. So nursing homes can be a variety of different things, but this is going to be 24/7, more aggressive treatment and or care for individuals in need of that. Assisted living facilities, again, are going to be 24/7 care, but oftentimes they're going to be a tiered system as far as what type of interventions and what type of care, depending on the individual. So oftentimes, there's going to be folks residing within the assisted living facility that may only need help bathing or simply just need food delivered to them or food prepped, and then it goes up from there. Some people need a little bit more aggressive care and treatment. The nursing home on the other side of that spectrum is, there's a lot more that goes into the actual care associated with somebody residing within a nursing home. Next, facilities that are becoming a lot more common and a lot more popular are actually independent care facilities. So in the city of Hermantown, they have Edgewood Vista, which is on Maple Grove Road by Sam's Club there. And they actually have all 3 of these capabilities within one infrastructure. So they have the independent care facility. So these basically are apartments. They have a dining center. They do have nurses on staff, but these individuals can come and go as they please. It's very independent. They can sign up for additional care and or treatments if needed. The assisted living side is going to be on the far side. And again, what I explained earlier is it's going to be some type of care facility. And then located in the middle is the memory care, which is more kind of your nursing home style as far as care facilities. We touched on hospice care. Next is vent homes. So inside Duluth Superior area, there is only one vent home, and it's located on Matterhorn Circle in the city of Duluth. So all of these individuals have some type of tracheostomy care, and they are always on a vent. So there are a number of respiratory therapists that are their primary care staff, and then they also have trained, certified, registered nurses there to take care of some other issues that they may come across. So basically, it's a nursing home with the caveat that they also have vent capabilities. Our outpatient surgical facilities, this can run into issues with that, because oftentimes they're not going to be attached to an emergency room in the event that something goes wrong. So oftentimes with that St. Luke's outpatient surgical care facility down on London Road, if something goes wrong within that surgical time, we'll be called as EMS providers in order to mitigate that and then get that patient transported to the emergency room. It just runs into a little bit of a logistical nightmare, because depending on the surgery that they're having, they need a somewhat sterile setting. And for us as EMS providers go, we do not really operate within that sterile setting. So trying to create a team-based approach to getting that patient out of that surgical suite and then into the ambulance and then eventually into the emergency room. So here, this is a picture of Edgewood Vista independent living side. You can see cars in the parking lot. Most of those are actually the residents who actually live there. Again, very independent from each other. Next is for these patients who do have these different types of special challenges, is using the knowledgeable caregivers that are actually on scene, because they have developed a relationship and have cared for these individuals for a long time, and utilizing their knowledge, their history can really make our patient assessment skills and our interventions go much more quickly and effectively. Then follow your protocols, follow your guidelines too, because there are going to be different patients with special challenges that have specialized equipment that treat these individuals. Don't try and think that you can figure them out, or even if you're guided or know how to use them, remember to always follow your protocols and your guidelines. So different types of diseases and conditions that again correlate into our patients with special challenges. Congenital disease, this is going to be a disease that is present at birth, and then acquired disease is one that occurs after birth and may be the result of an exposure to a virus or bacteria or other medical condition or trauma. So with this, you can kind of correlate this into our diabetic patients. Type 1 diabetics, oftentimes this is going to be congenital disease because they are born with it. Type 2 diabetes oftentimes is acquired over time based on lifestyle and other hereditary and disease processes. So some specialized equipment that I was talking about. Now we did learn about CPAP, which is our continuous positive airway pressure. So a lot of individuals who have COPD or sleep apnea oftentimes will actually have these CPAPs readily available to them. CPAP is in the state of Minnesota scope of practice. It's just, again, you have to follow your specific protocols and your guidelines if you are going to go ahead and use this device. Next, what we could see, I mentioned this within our vent homes, is tracheostomies. So this is going to be a surgical opening in the neck and then into the trachea. So if somebody's going to be on a long-term vent, they will not intubate them, or they will go ahead and extubate that patient and actually create a tracheostomy. So as far as us, when we're dealing with a tracheostomy and or a stoma, sometimes we're going to have to go ahead and suction that stoma out. So with that, we're going to use a French suction catheter. Oftentimes we're going to have to put just a little bit of sterile water into that opening and then go ahead and suction it out. We could also have, with that tracheostomy patient, the patient cough, and then oftentimes we can actually remove that mucus plug from them. A ventilator, acronym is going to be ATV, or automatic transport ventilator. With that, we can specifically tailor a respiratory rate, the tidal volume that they have, and a specific percentage of oxygen that that patient is actually going to acquire. Now, these devices are either going to be on our advanced life support ambulances, or in the event that we're transporting a patient and we're a basic life support crew, oftentimes we can actually take a respiratory therapist with us and that ATV can actually fit inside of our ambulance, and they can continue that vent treatment when that patient is being transported. So here's an example of that CPAP. So this is specifically designed for the patient who's got sleep apnea, but this CPAP model looks very similar to what we would use on an EMS service. Here we have that tracheostomy. And then this is going to be an example of an ATV. So they do come in different sizes too, in order to actually get that specific piece of equipment into the ambulance. So some specific special equipment that we may see with patients on cardiac devices. First is a pacemaker. So this is going to be implanted under the skin. It's got wires implanted in the heart to modify the heart rate as needed in order to maintain an adequate perfusion at that point. Now there's two different types of pacemakers. There's demand pacemakers or constant pacemakers. So constant pacemakers, what they're going to do is they automatically and always trigger a specific heart rate for that patient. Demand pacemakers, if a patient's heart rate falls below a specific number, that's where that pacemaker will actually trip into play and start generating. Or if a patient is missing a heartbeat, it will try and create a regular heart rhythm for that patient where it might fire once every couple of beats once they need it. Patients who are prone to going into different cardiac dysrhythmias, such as VTAC, and some more severe cases of atrial fibrillation, we could see an automatic implanted defibrillator. So it's very difficult to tell the difference between a pacemaker and defibrillator. Stitched underneath the skin, it just looks like a hockey puck. So that's where you're just going to have to dive into your sample history. But what a implanted defibrillator is, it's implanted underneath the skin, and if it identifies VTAC, then it'll go ahead and deliver that shock in order to get that heart rhythm back to a normal sinus rhythm. So basically think of this as a small AED that's portable with that patient. Next, we could see a left ventricular assist device. So remember, for our geriatric population where we have that enlarged left ventricle and it might not do as an efficient job as we need as far as preload and afterload. So this is going to help generate the proper afterload out of that left ventricle. So there's an example of our pacemaker. Most of the time it is going to be underneath that portion of the skin. If for whatever reason it's on the patient's right side and this patient goes into cardiac arrest, remember we never want to cover that pacemaker or that defibrillator with an AED pad. So we're simply just going to put that AED pad lower, and so we're not covering any type of that pacemaker defibrillator up. And then this is an example of that LVAD. So that box is going to be located on that patient's belt or on that patient's hip. And then that's actually implanted underneath the body as far as that pump and housing system. So some different GI devices that we can see: feeding tube. So this is actually pumping a nutrient paste directly into the stomach in the event that that individual can't actually digest food and or eat food. The urinary catheter. So this is inserted through into the bladder through the urethra. And so in the event the patient can't control their bladder, or if their urethra is damaged, something along those lines, that urinary catheter is implanted, and then the waste material from that actually gets deposited into a bag. So big thing to remember if we're transporting a patient who's got that catheter bag, to make sure that catheter bag doesn't get kinked or damaged, and then also have it hang down lower than the hip level so that we're letting gravity actually drain that system. An ostomy bag. So this is basically your waste bag. Remember, that is attached to the patient. There's not much that we have to do with that. Just keep that in mind. And then dialysis treatment, when that patient does have that shunt, big thing that we want to keep in mind is we don't want to take a blood pressure where that shunt is. And then also oftentimes we may be called for excessive bleeding out of that shunt or possible infection. So possible bleeding or severe hemorrhage coming from that, we're just going to apply our direct pressure. And then something that we don't see very often is going to be our central IV catheter. If this is placed, this individual is already in a long-term care facility, most likely a hospital when they are receiving anything like this. Their feeding tube. Different style of that feeding tube where it's actually located directly into the stomach. Here, example of that catheter bag. So again, if we're transporting that patient, that will fit, just right on the side of the stretcher. If you're out in the community, what have you, it's good practice to go ahead and cover that with the sheet just to protect that patient's privacy. Then our ostomy bag. And then that's where our shunt is going to be located for our patients who are on dialysis. And then there's our central line. So again, central line, this is outside of our scope of practice as any of our EMS providers go unless you're critical care. So it's good to be aware of it, but there's not much that we're going to be actually doing with that central line. All right, so that does it for chapter 40, which is our patients with special challenges. A lot of these things, it's just going to come with time and actually interacting with these individuals to start to become more and more comfortable with them. All right, thanks everybody.